Hello, everyone, and welcome to another audio podcast. This is the Shientist, and this is another Storm Robotics production. In this episode, or this series, around the Busta Cap episode. Today, I'm going to talk to you about the use of platelets and granulocytes. There'll be two parts to this overview. This is going to be part one, um, and um, and what and in relating to what's already been highlighted in this series so far, we talked about the use of red cells, and also before that we talked about what the blood and hemopoiesis. And so in this particular in this particular overview, or part one of this overview, um, um, uh, um, uh, I'm going to talk about, as I mentioned, the use of platelets and granulocytes. As you know, this is the Shientist. So to begin with, platelet to give to give an initial perspective, platelet concentrate transfusions, in relating to those who might have specific or particular hematological deficits, or issues around the physiological components that make up hematological parameters. Platelet concentrate transfusions can be or may be indicated in a variety of clinical conditions and under particular considerations between the MDT. And MDT, again, is an abbreviation for multidisciplinary teams. So this means basically where you have those who are in for example, who might be hematology specialists, and there might be hematology scientists, for example, and together they make a decision as to whether an individual may require platelet concentrate transfusions based on particular clinical conditions, and considerations. And so an example of this might be where patients have severe thrombocytopenia, or platelet dysfunction. So thrombocytopenia, again, is where you have those who have low platelet counts, and basically, um, uh, um, under 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 the under morphological from a morphological perspective, blood morphology perspective, thrombocytopenia will look, where the normal reference range can be between something around 150 to 450 or 500, under the microscope, from a laboratory medicine reference range. Under morphological conditions, or under microscopy, what would happen is that thrombocytopenia would look like would actually appear as though the patient, an individual, may not have very many platelets, and there may be many reasons for that. So the platelets are actually the smallest cells under hematological conditions, and basically, under after blood films have been stained under morphology, or under microscopy, the platelets would appear a sort of a lilac blue type color, and basically they would be the smallest cells under the microscope. And if a patient has thrombocytopenia, there would be either what's known as platelet clumping, so where platelets are clumped together to appear as though that there is no in some regard normal normal platelet function, because in normal hemopoiesis there can be some platelet clumping, but in thrombocytopenia that can with thrombocytopenia platelet clumping appears in a way more obvious, but also can give an indication as to whether the patient is actually has not just a low platelet count, but could have an underlying condition that prompts that thrombocytopenia, or and again a platelet dysfunction. And so with symptoms of bleeding or hemorrhage, with symptoms of bleeding or hemorrhage, and these are also where individuals or candidates for platelet concentrates can be used to induce hemostasis or hemopoiesis, again or also to prevent intracranial bleeding and or hemorrhage through organ organ systems. So generally speaking, patients with severe thrombocytopenia can have general issues around the ability to clot through physiology or through what is known as hemopoiesis. And so this also then leads into a sort of a kind of a definition from a quantitative perspective what thrombocytopenia is. So literature, and I will give a source of reference towards the end of this overview. But severe thrombocytopenia historically has been defined quantitatively as a platelet count less than 20 times 10 to the 9 liters per minus 1, which is basically a large number of platelets that have been reduced from a physiological, from a hematological perspective. And again, the conditions might be that a patient could be bleeding out. It could be a pregnant woman, pregnant female who might have lost quite a lot of blood through pregnancy. There could be a number of reasons. So generally speaking, thrombocytopenia is a reduction in platelet count caused by a number of reasons, and to kind of complement to understand thrombocytopenia, clotting tests and investigations can be done. So conditions associated with severely decreased platelet counts can include bone marrow failure in conditions such as what is known as aplastic anemia. Then there could be bone marrow suppression in patients receiving chemotherapy or radiation therapy, and also bone marrow replacement by malignant cells, as in the case as what is known as acute leukemia or myeloid metaplasia. And generally speaking, hematological conditions, in the most part, and again, literature may differentiate between some of the sort of aspects that relate to the reference ranges from laboratory medicine perspectives. There may, generally speaking, platelets, because of their general physiological, their hematological bases or bases, because they are small. They're small generally from a morphological perspective. Generally platelets are more vulnerable to being more vulnerable where hematological conditions are concerned. And then other conditions associated with severely decreased platelet counts or thrombocytopenia might be where patients have platelet consumption disorders, massive volume replacement or severe traumatic bleeding, as in the case of some of the conditions known, some of the bleeding conditions, and also what is known as ITP, or abbreviation is ITP, which is idiopathic thrombocytopenia, and also where patients might have abnormal platelet function as part of their hemopoiesis, and then wherein again most hematological conditions not only are followed up through hematology, but there are also sort of laboratory investigations which are linked in relating to clotting studies to actually identify the extent of the factors, and I've mentioned in one of the initial episodes in this particular series that clotting factors, there's an intrinsic pathway, there's an extrinsic pathway, and there's a common pathway. And generally the pathways where clotting is concerned, they do join up in some part, but generally if there's deficits or deficiency between the intrinsic and extrinsic pathways, and also the common pathway, generally there can be abnormalities that prompt investigation around abnormal clotting, generally speaking. Now, concentrations for platelet therapy are also important when there is a likelihood that benefit is remote. So what this means is that there can be a demonstrate, and that there is the contraindications are demonstrated where there's platelet refractiveness or refractoriness, and there is stable patients with thrombotic thrombocytopenic purpura. So thrombotic thrombocytopenic purpura, or TTP, is basically where a patients can have for example petechiae on their skin, and give a bruising like appearance on the skin, which actually could warrant investigation for platelets or the platelet count. And generally, if there is indication after doing specific laboratory investigations, then generally speaking, it could mean it could well mean further clotting studies or investigations may be required to identify underlying causes for what could be thrombotic or thrombocytopenic purpura, or again TTP. And if there are issues around, for example, the full blood count as well, generally that could indicate that patient might have microangiopathic type of a microangiopathic hemolytic anemia, which also could well be linked to an underlying cause of an underlying issue or a concern that relates or regards the renal function or kidney function. Because remember, in particular conditions, where TTP is concerned, there can be issues with the blood vessels that lead to and from the kidney that could also be linked back to the clotting cascade, which is again to do with the intrinsic, extrinsic, and common pathways around clotting. And also contraindications for platelet therapy are when when there is a likelihood that benefit is remote, and where patients have heparin-induced thrombocytopenia. So basically, in a kind of, again, in a contraindicatory way, or almost counterintuitive physiological way, heparin is an anticoagulant, and normally what would happen with heparin is that it would loosen up in a way some of the blood vessels, some of the vessels, blood vessels, so that or at least some of the vessels, so that blood flow is more open in relating to the blood vessels, where to and from different parts of different parts of from a physiological perspective, where generally heparin would loosen up the blood flow, so that generally, systemically speaking, there is a less probability of issues in relating to anemia and hemoglobin issues, and thrombocytopenia. Thrombocytopenia can occur still, however, even with patients who are induced with heparin. and so platelet concentrates from donors of the identical ABO and D group, ABO blood group, and what is known as the D group, which is in relating to those who are anti-D negative or anti-D positive platelet concentrates from donors of the identical ABO and D group can be or should be the component of choice when it comes to when it comes to when it comes to when it comes to where patients may require platelet transfusion, and when they should be used. Platelet recovery of both major and minor ABO compatible platelet transfusions may be impaired to some extent, but this is not usually clinically significant. So what this means is that generally sort of irrespective irrespective of the incident of wherein after platelet transfusion has been implemented, generally speaking, the recovery around that is not normally an issue for donors. Normally, donors who have platelet transfusions recover quite quickly, or generally generally recover quite quickly after having their treatment. A more important consideration concerning donor ABO antibodies is the avoidance of what's known as acute hemolysis, which may occur after what is known as ABO incompatible platelet transfusions. So generally, typically, incompatible platelet transfusions, wherein typically with transfusions of high titer anti-A to A recipients. So what this means is in sort of emergency situations, for example, if there is no compatible sort of compatible ABO, if there's no if there is an emergency and platelet transfusion is required, then in the best case scenario, then obviously ABO compatible blood transfusions or platelet transfusions, should be the obviously the blood groups of choice. But in emergency situations, for example, if there are not enough donors, whether from red cells in relating to red cell donors for blood transfusion, or platelets, then generally speaking, in emergency situations, it could well be that that where there is incompatibility, then donors may unfortunately build particularly antibodies having been transfused. However, every effort from a laboratory perspective, from a laboratory medicine perspective, serological perspective, is made to ensure that that not only is ABO compatible components given or provided, but also from a subgroup of blood, for example, where you have rhesus groups as well. From that perspective as well, generally speaking, every effort is made to ensure that recipients donors who require platelets or red cells or any other components, again, granulocytes as well. Generally speaking, every effort is made so that ABO compatible components are provided, and normally, generally speaking, the number of units that are required for a transfusion are generally sort of available regionally, based on requirement from, for example, blood donation sites or centers. Now, group O platelets should only be used for A, B, and AB patients if they have been tested and labeled as negative for high titer anti-A and anti-B. I'm going to repeat that. So group O platelets should only be used for A, B, and AB patients if they have been tested and labeled as negative for high titer anti-A and anti-B. Now, as I mentioned before, the blood groups can have you have your A, you have your B, you have your AB, and you have your O. Generally, each of those blood groups have certain antibodies that align with them in some regard. However, generally speaking, it's important that group O platelets should only be used in AB patient for A, B, and AB patients, because generally speaking, the hematological stance on patients who have these blood groups are in some regard generally, with some components versus other components, are more probable. There's high, in some regard, are more sensitive or high. There's high probability to an extent to have antibodies if more than one transfusion is required. So this is important. D negative platelet concentrates should be given where possible to D negative patients, and D, by the way, isn't a particular blood group, but it applies to mainly females who are at sort of the within the age range, where they are more viable for pregnancy. So D negative platelet concentrates should be given where possible to D negative patients, particularly to menopausal females of any age. So premenopausal in this regard, or at least in this context, means those who are viable, who are viable to fall into the pregnancy age range. So D, again, D negative, oh sorry, the D group isn't a particular blood group, because as I've mentioned, there's only A, there's B, ABO, sorry, AB, O, and AB. D is actually relating to where patients from female backgrounds can produce an anti-D in from a serological context. So generally, D negative platelet concentrates should only be given where possible to D negative patients from female backgrounds, any age, and particularly those who are those who are pre-menopausal. If D positive platelets are transfused to a D negative pre-menopausal females of any age, it is actually recommended, at least literature has historically said and informed, that is recommended that anti-D immunoglobulin should also be given. So this is when I was saying, this is why in the previous slide I've talked about premenopausal and how anti-D can be can actually result after for example, if a female falls into a pregnancy, and for example has a unfortunate miscarriage, an anti-D can result. And it is recommended that anti-D immunoglobulin be given, and anti-D generally is in transfusion laboratories is actually available. Another thing I want to talk about a little bit about is something about leukocyte concentrates. So leukocyte concentrates, primarily granulocytes, may be of value to patients with something known as severe neutropenia. Now, neutropenia is where you have those white cells, white blood cells, particularly where apart from what is known as, you know, those actual leukocytes or lymphocytes, neutropenia or neutrophils are important in prompting an attack against bacteria and other microorganisms that can cause harm in general physiology. And so basically patients with severe neutropenia or low neutrophil count and who have a life-threatening systemic infection and a life-threatening systemic infection and uncontrolled by antibiotics. So basically leukocyte concentrates are provided or are issued prescribed and issued based on life-threatening systemic infection, and generally speaking, these are where in the organizations in blood centers where blood components are made and produced, generally speaking, leukocytes would are made up with primarily with granulocytes. So patients who most frequently are considered appropriate candidates are those with low platelet with low neutrophil counts or neutropenia induced by chemotherapy or radiation therapy. Because what happens, unfortunately, with chemotherapy or radiation therapy is where the white cells or those cells that are normally part of, from a hematological and immunological perspective, generally those cells are completely wiped out or more or less wiped out when such treatment is provided or given as a as part of the hematological condition individuals or patients might have. And so generally speaking, the neutropenia is induced, and then thereafter, when chemotherapy or radiation therapy is provided or given, then generally speaking, unfortunately, the immune system becomes more compromised, and thus, if more sort of radiation or chemotherapy is given, then generally it can unfortunately cause more systemic problems subsequently, which is why generally speaking, patients who have specific neutropenic or platelet type conditions, generally speaking, clinicians with laboratory teams can actually request more can request different types of blood components for patients, so that patients have more than one component if that one form of blood component, if that actually helps and prompts a source a sort of hematological sort of recovery as part of their hemostasis. Granulocytes can be stored at anything between 20 and 24 degrees Celsius, and so generally around room temperature, without agitation. And if you recall that in a previous audio or podcast, I mentioned that, for example, platelets can be stored at room temperature as well, but they have to be kept on an agitator, because otherwise what will happen is that the platelets can stick, because generally, as we know, platelets are important for clotting, and if they are left without agitation, then basically under room conditions they stick, and so it's important that they are stored at room temperature without agitation for at least up to 24 hours, and is best, however, to transfuse granulocytes and platelets as soon as possible after they are requested for use. And granulocytes are given as ABO and D compatible and must be cross-matched. So again, there's in laboratory medicine, there's serological investigation that takes place, where laboratory scientists themselves they cross-match the blood and components, the blood they cross-match the blood against against donor and recipient, so that the donor so that the recipient who require particular components, again in this regard granulocytes, so that they receive those that are best cross-matched, and so generally, again, blood components have to be sort of compatible from an ABO and D perspective. And that's where I'm going to draw this particular audio podcast to a close. I'd like to provide some sources, some citations or references, and some acknowledgements. So again, as in the previous audio podcast, I referred to a reference, and that was known as the International Society of Blood Transfusion, or ISBT, and it was the Science Series in 2020, and it was a special issue, and its full title of this book publication is The Introduction to Blood Transfusion from Donor to Recipient, and it's available actually on the ISBT website, and it's also at present it's freely downloadable as well. The whole book is freely downloadable. There's also I'd like to acknowledge Malcolm Needs, who is a transfusion scientist and practitioner from the United Kingdom, for his approach to hematology, transfusion, and serology. And acknowledgement to Professor Ken Jones, who's an emeritus professor in immunology in the United Kingdom, for the immunology perspective. And also I'd like to acknowledge have an acknowledgement to Professor Tim Chambers, who I would consider as an emeritus professor in pediatrics, and pediatric nephrology in the United Kingdom, for the nephrology perspective. So generally, I will now the audio. So this was part one of this audio podcast, and there will be a subsequent one around this. And once again, this was part of the Busta Cap episode, and this has been the Shientist, and this has been a Storm Lobostics production. And I hope that anyone listening listening to this audio podcast listens out for the next one. Apologies for the delay on the last from the last one to this one. I had been away on some emergency work, so hopefully I'll catch you on the next one. Thanks for listening.